Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Welcome to today's Thinking Thoracic episode, where we'll be discussing the best papers in thoracic surgery in 2024. I'm your host, Jeff Yang, and am joined by Dr. Linda Martin. Dr. Martin is the Chief of Thoracic Surgery at University of Virginia and a renowned expert in thoracic clinical trials. She is chair of Alliance Thoracic Surgery Group and oversees the development of numerous groundbreaking clinical trials. Recently, she was the 2024 program co-chair of the ISLC World Conference on Lung Cancer. And over the past decade, she has led Ginsberg Clinical Trials Day at General Thoracic Surgical Club. Every year at General Thoracic Surgical Club, Dr. Martin presents a list of the best papers in thoracic surgery. I absolutely love this talk, and I'm really excited she's here to share this list and discuss these papers with us today. Dr. Martin, thank you so much for joining us.
Thank you for inviting me.
Great. So to get started, can you give some context behind this best papers list?
Yes, Jeff, thanks. So a while ago, we started thinking, we spent so much time talking about the trials that are in development or actively accruing, and not so much time on, well, what actually were the results of those trials? How should we adjust our practice? And so much time and effort and resources go into those trials, both the patient sacrifices, the developers, the costs, et cetera. And it's so important for us to actually propagate those trials. So I started out with just a what happened to that trial and gradually morphed to sort of what are the key papers we need to know about. So I would say these are not necessarily the best papers, because who knows how you judge that, but papers that I think are most important and sort of practice changing. And I try to include things that are in journals that we might not look at all the time that are still really important for surgical practice. So I have a list of journals that I go through every year. I go through Twitter, which is a great way to keep up with what's coming out. And then I also have now worked out a deal with the editors of JTCVS and the Annals of Thoracic Surgery, where they'll send me information about the most cited and most downloaded papers. And so I have some actual statistics to go by to see what's grabbing people's interest. So if your paper isn't on the list, don't dismay. There isn't a lot of science in how I choose these, but it's just my best effort at trying to see what I think is practice changing and things we need to know.
Great, thank you. I'm really excited to go over this list. And today we'll talk about these broad categories. I know at GTSC you grouped these papers into these specific topics. So for today's podcast, we're going to talk about the general cancer papers that you thought were of note. Then we'll talk about the top Annals of Thoracic Surgery and JTCVS papers, and then move to mesothelioma, lung cancer, esophageal cancer, benign esophagus. And then you have this fun category called professional matters. So we'll cap it off like that. So let's turn to your first category, which was the general cancer topics.
Yes, I don't always include this topic, but there were some interesting things here. So one is the cancer statistics paper that comes out every January in the CA Cancer Journal. So if those of you aren't aware, that is a great way to get really good epidemiologic data on what's happening in every type of tumor by state, but across the country, by gender, et cetera. And it was notable this year and made a lot of press releases because cancer mortality was down by over a third in the last 30 years. So that's a really big improvement, a lot of lives saved. But they noticed a little bit more cancer in sort of what I'd like to think of middle-aged people, 50 to 64, and cancer rates in women outpaced men. and in specifically lung cancer incidence in women surpassed men with about 5,000 more cases per year than men. And then also, we always give the statistic as lung cancer doctors that lung cancer deaths are more than the combination of breast, colon, and prostate. But actually, for the first time, that's not true because we're making such an improvement in lung cancer deaths. So I thought it was really important to highlight this year. But these things come out every January. If you're ever looking for them, they're great references for papers and things like that. And then the other paper I thought was just good general information for us to know because we're surgical oncologists of the chest for much of our practices. And there's a really nice overview of radiation toxicities, mechanisms of different types of radiation. How do you manage it? What do you watch for in different organ systems? And this came out in the Lancet in 2025 in their January issue. So, and the first author on that is Virginatus. Ioannis Virginatus is the first author for that. So just again, one of those things, as a cancer surgeon, you should be aware of these other modalities, and thought that was a good review paper for everyone.
Great. Thank you for getting us started with that overview with two important topics. Let's move on now to the top cited and downloaded articles for Annals of Thoracic Surgery.
Okay, great. So this was anything that was published in 2024 or later. And I'll mention that JTCVS does it a year behind that, which kind of makes sense because then there's a little more time for stuff to have been read and cited. But so this was anything 2024 or later. And I have 7 papers that were sort of equally matched. Some of them were at a tie for a number of cited and downloaded. So looking at the Annals of Thoracic Surgery, they send me their data for anything published January 1, 2024 and beyond. And I'll mention JTCVS does a little differently when we get to that. So the top cited and viewed paper came from the team at Mass General, and Dr. Yang's a co-author on this paper, and it looked at segmentectomy versus lobectomy for patients with visceral pleural invasion. And the take-home message there is that whether you do a segment or a lobe, the outcomes are the same with visceral pleural invasion. So you shouldn't go back and do a bigger resection if you see that on your final pathology. And this comes up later in our discussion too with one of Dr. Altorki's secondary analyses. And then there's a paper about general thoracic surgery database, sort of updates on that. And that's always highly read. And then there's 2 papers, one actually from my team, and both of them are looking at opioid use beyond the perioperative period in the setting of enhanced recovery, and they have different messages, so worth looking at those. And then there's a paper about lymph node evaluation in 2 centimeter or less pure solid tumors, first author Choi. And then impact of surgery on disease progression and survival in mesothelioma, coming from Nakamura and Associates. And then lastly, one of my papers made the list too. And I swear this isn't, the decks are not stacked. This is the first time my own papers made it. But this was on our 5-year sustained outcomes of thoracic enhanced recovery at UVA. And then moving to JTCVS, they gave me the data in a little bit different format. So we have one set of papers for top cited and one for top viewed. And again, this goes back to 2023 so that there's a little bit more time for the usage to accumulate and show up on the statistics. So for the top cited papers, it was a CALGB Altorki analysis, post hoc analysis. And I'm going to come to that again later in the talk. Also another paper about neoadjuvant therapy and sleeve lobectomy, long-term outcome of patients with peripheral ground glass opacity, dominant lung cancers with sublobar resection from Yoshino and others, extent of surgical resection for a subsolid T1 N0 is a wedge acceptable from Zhang and others, and then 2-year outcomes of clinical N2 to 3 esophageal squamous carcinoma, a secondary analysis from the NICE study, and that's from Yang and others. And then for the top viewed papers, again, I'm going to rush through this a little bit, but there's a consensus document on subsolid nodule management from AATS panel. There's another expert panel that we had reviewed last year, but that's about multidisciplinary management of early stage lung cancer. And that got a lot of attention, both of those like 7,000 or more views. And then another ground glass opacity paper, a surgery for oligometastatic disease, which is a really nice review from Mara Antonoff and several other co-authors from multiple institutions. And then surgical outcomes in, I think it's the NeoStar study. And so that's Hope Feldman is the first author, but also Boris Sapesci and Tina Casconi. And then lastly, surgical management of lung cancer with limited metastatic involvement of the brain, also coming from Dr. Yang's group, was rounding out the top viewed papers for 2023 and into 2024. So again, these are ones we're going to have to post because I don't have enough time to go through detail on all of those.
Thank you, Linda. That was a great overview of all of these papers that we'll make sure is accessible when we release the podcast. Now, moving on to mesothelioma.
Okay, so the big paper of 2024 for mesothelioma is, of course, the MARS-2 trial, which has gotten a lot of attention and a lot of editorialization, shall we say. And this was published in the Lancet Respiratory Medicine in May of 2024. And I'll point out, we had a really great in-depth discussion at our last year's GTSC meeting in 2024. And so we didn't spend a whole lot of time this year talking about it, but essentially the take-home messages from this were that in patients with any type of mesothelioma, all three subtypes, they were offered either chemotherapy alone or surgery with chemotherapy. And that surgery was a pleurectomy decortication or extended pleurectomy decortication. And surprisingly, the patients in the surgery group actually did worse than people who didn't have any surgery. They had more adverse events. There are a lot of nuances here, a lot of different opinions. And so I don't want you to just take this at face value. So if you're a meso person, you're going to want to know this paper backwards and forwards. But I think all thoracic surgeons should be aware that this came out. It's a really big deal. And reason to really think carefully before you rush into an operation like this, or just to remind that you probably ought to send these patients to specialized centers where they may have clinical trials or other protocols that might be able to refute these findings. And I will mention too, there's new staging information that came out with the 9th edition. And the IASLC has published quite a bit about all of that. I didn't go into discussion on it during this talk because Dr. Valerie Ruch gave us an overview. But if you're interested in mesothelioma, you're definitely going to want to look at those publications from IASLC on the new updates.
Thank you, Linda, for highlighting MARS too. That's such an important trial. And just wanted to give a quick shout out to Dennis Weigel and Aaron Mansfield's study. They are currently doing a study called multimodality therapy with immunotherapy in stage 1 to 3A sarcomatoid mesothelioma. And they only need 26 patients for accrual. Given what Linda had just talked about with MARS, I think it's going to be really important for all thoracic surgeons who can do this to accrue to this trial, because right now the latest randomized trial with MARS-2 does show that surgery is not beneficial and associated with worse outcomes. But in 2025 and beyond, there's a lot more to explore and investigate in this area. All right, so then a major topic for today is the lung cancer papers.
Yes, and there are so many important publications in lung cancer and more each year because of so many practice-changing trials. So the first paper that got a lot of attention, and this came up in my independent review, has nothing to do with the co-host here, but this is a paper from Journal of Clinical Oncology, which is one of the highest cited journals, from March of 2024, so almost a year ago. And it's looking at the way we think about smoking exposure in terms of estimating risk of lung cancer. And this idea of pack years may be needed to be rethought. So Dr. Yang and his team, including Alex Potter, who is the lead author, they looked at if they used pack years or just total years of smoking. So not so much a pack a day, but what if it was less than a pack a day? Does it matter? And then it looked at differences by race. And so essentially people who were diagnosed with lung cancer, you look back and see how many of them would have been eligible for screening. And if you also look at that broken down by race, there was a really big disparity between Black and white patients in terms of how likely they would have been screened if they met the criteria. Whereas about 57% of Black patients who ultimately got lung cancer would have been screened, and only 74% as compared to 74% of white patients. And by changing from 20 pack years to just 20 years and taking away the amount of cigarettes smoked, it completely got rid of the disparity, and both groups would have been screened more effectively. So they would have gotten up into the 82 to 85% rate, where when later diagnosed with cancer would have qualified for screening had they gotten it. So it's such a big deal that the NCCN guidelines have actually been changed already because of this publication. So now the latest version of NCCN says either 20-pack year history or 20-year history of smoking now would qualify for lung cancer screening. So that's a huge deal. And in fact, I've heard in many meetings that this new criteria is being called the Potter criteria in honor of the first author, Alex Potter, who, by the way, is a college student, soon to be a medical student at Harvard, probably. So anyway, keep your eyes out for Alex Potter's work because it's been really tremendous. The next group of papers we're going to talk about, I'm going to suggest we devote an entire podcast, probably with Dr. El Torki, to talk about everything that has come from the CALGB 140503 trial, which is sublobar versus lobar resection. I reviewed it at the GTSC, but there's 4 recent papers and 3 abstracts that are relevant, and there's even a couple of older papers. So I think that might be prime time for a separate podcast. What do you think, Jeff?
Yes, I think that's a terrific idea. As I look at all these papers that we talked about, I think that would be a great idea.
So we're going to skip that for now. Another trial that I've been hearing about this idea for years and years, and I wondered whatever happened to it, and that's how I went looking for it. But this is a paper that's published again in Journal of Clinical Oncology, October of 2023. So it's slightly older than some of these other papers. This is looking at this whole idea that some of the drivers of oncogenesis or even cancer progression has to do with inflammation and this concept called the inflammasome, which is sort of a microenvironment where there's IL-1 beta is a big factor in driving cytokine production, angiogenesis, tumor transition so that it can metastasize, growth, invasion, all these things. So the thought was, well, if you can target that inflammatory microenvironment, it might change cancer risk or cancer progression. And it was sort of discovered by accident in a trial called the CANTOS trial that was used for cardiovascular risk reduction using this drug that blocks IL-1 beta called canakinumab. And they happened to notice a big reduction in lung cancer mortality as sort of a secondary endpoint that was unexpected, which prompted interest in, hey, should we do a trial for this? So ultimately, a trial was done using canakinumab. We had entertained using another drug, colchicine, because it was a heck of a lot cheaper, like 5 cents a pill. But ultimately, canakinumab was the study agent used. So they looked, it was a phase 3 randomized trial, almost 1,400 patients. Stage 2 to 3B that had been resected. After surgery, they would get this drug, kind of like you would give tamoxifen, almost like chemoprevention. And they got this injection, canakinumab, every 2 weeks, I think it was, for about a year. And then they looked at disease-free survival, and it was negative. There was really no difference in disease-free survival. So a little disappointing, but I think important for us to realize that this might not be the right avenue, or that the amount of treatment is not really effective. Maybe colchicine is cheaper, can be given for a longer duration. We'd see a difference, but for now, this idea is not really moving ahead. However, there's some interest in looking at specifically high-risk populations, and there's ongoing trials to use this as chemoprevention in that setting. But again, I think a lot of people were approached about this, or maybe had enrolled patients on the trial, and I think it's worth knowing what actually happened. The next trial that I think is noteworthy, and I'm hoping most of you have heard about already, is called the ALINA trial, ALINA. And this came out in April of 24 in New England Journal of Medicine. We also talked about it on a GTSC podcast. So if you want a really in-depth discussion, you can look on the GTSC site for that podcast. But this was looking at patients who have this thing called an ALK rearrangement or ALK positive in adenocarcinoma. And it's going to be around 5 or 7% of all lung cancer, early stage adenocarcinomas. And they found when this mutation was identified in patients that were stage 2 and higher, 4 centimeters or greater, if they got this drug for 2 years and nothing else, no chemo, no radiation, just this drug, called alectinib, and it's a pill, so it's pretty easy to deliver, that it had a massive impact on disease recurrence. We don't have survival data yet because it's too early, but the recurrence rate was a hazard ratio of 0.24, so a 76% reduction in recurrence with this pill. And even more exciting was that it reduced brain metastases, which are especially common in this population. So that was even better with a hazard ratio of 0.22. So if you aren't already testing your resected patients for the ALK rearrangement, you really need to. This is now standard of care and incredibly impactful, easy to give, low side effect profile. The next paper is a 5-year follow-up of something that's of great interest to me. And this is for stage 3 patients. The trial's called NADIM, and it came from a Spanish cooperative group. There's 2 NADIM trials. One was a phase 2 non-randomized, and then NADIM 2 is one that was a randomized trial. And so both have been in the press quite a lot. They've had a lot of sort of secondary endpoint publications come out over the last several years. This NADIM 1 study, which is just the single arm phase 2 trial, just reported its 5-year results. So remember, we're talking about stage 3. Historically, these patients have a survival rate of 20 to 25% in the pre-immunotherapy era. This was all comers with stage 3, meaning like T4N0, T3N1, as well as the N2 positive patients. And they got a combination of chemo and checkpoint inhibitor with nivolumab, resection, and then they got, in this study, a year of nivolumab, and there's some differences between the NADIM 1 and 2 design you might want to look at. And then this is just showing us what did they get at 5 years, because we've all been kind of wondering. So remember, our benchmark is 20-25% survival. In this group of 46 patients, it was 69% 5-year survival. So really, really impressive. I always like to cross-trial compare to Pacific, even though it's illegal, but I like to do it anyway. And the 5-year survival in a non-surgical approach to patients who were considered either borderline resectable or unresectable or not defined had a 5-year survival of 43%. So with surgery and the NADIM strategy, 69% survival versus 43% with a non-surgical approach, I know which one I would pick.
These are incredible numbers and just really striking. 69% 5-year survival.
Yeah, it's almost as good as what we see sometimes with stage 1 disease.
Yeah.
It's crazy. So really, really remarkable. Obviously, it doesn't mean it's going to apply to every single stage 3 patient, but a patient who you think might be operable, it's really worth seeing if you can make that happen.
Yeah, exactly.
And speaking of, the next paper is exactly about that. So resectability is a very hot topic, one which is very difficult to define. But there's quite a few groups that are doing their best to define it, or at least give us a little bit more of some guideposts on what would be resectable or not resectable. So the EORTC, which is a European cooperative group, got together and did survey data of different specialists involved in lung cancer care to try to figure out where there's agreement or disagreement. So, they go through all the different T statuses and then everything from N1 up to N2 in terms of bulky disease, multi-station disease, et cetera. And similarly, the STS just recently published a consensus review on the subject, which doesn't necessarily agree with the EORTC, but they have a nice sort of like 2-minute video summary of their findings. And I know you can find that on their YouTube channel. Also, that's something we can put a link in with the podcast publication. And then 2 other really big studies that were in the New England Journal or Lancet in the last year that were sort of peri-op trials. One is Checkmate 77T. This came out in May of 2024 in the New England Journal. This is a trial led by Tina Casconi at MD Anderson, but is internationally accrued to, once again, stage 2 to 3, perioperative trial. In this one, patients had to be documented to be wild type or normal in terms of EGFR and ALK mutations. And it was 461 patients, endpoint of event-free survival. And they put patients through either neoadjuvant Nivo and chemo surgery, and then more Nivo for a year. The control arm was chemo alone, pre-op, and then surgery, and that's it. So they would either get just the neoadjuvant chemo and that's it. And this trial, again, was very positive with a much higher rate of pathologic response, 25% in the treatment group versus 5% in the control. Major path response, meaning less than 10% viable tumor, was 35% compared to 12%. And then the primary endpoint of event-free survival was 70% compared to 50%. So again, another trial showing really strong efficacy for using checkpoint inhibitor in combination with chemo as a perioperative study. This, like so many, is really only telling us about the impact of the neoadjuvant part of the treatment strategy, because the results are not mature enough. This is only out to 18 months, so we don't know yet what the impact is of the adjuvant therapy. Also, like many other trials, it looked like the high PD-L1 patients and the more advanced stage, like stage 3 compared to stage 2, derived more benefit from the strategy than those in the less riskier groups. And then last in this section is Keynote 671. So another perioperative trial. This is just giving us more mature outcomes. And this was looking at the survival outcomes because their early reports were just on event-free survival. So this came out in the Lancet in September of 2024. First author for this is surgeon Dr. Jonathan Spicer from McGill University, with quite a few illustrious co-authors. So again, stage 2 to 3, just like the last trial we talked about. This one was almost 800 patients, and this is looking at the overall survival. Other results have been reported previously, and they found that at a 3-year time point, the overall survival in the treatment group was 71% compared to 64%. And again, this was patients who had Pembro with chemo, surgery, and then more Pembro. The control group, very much like the last one we talked about, was chemo up front for 4 cycles, then surgery, then placebo. So we're seeing a 7% absolute difference in survival at 3 years. The hazard ratio for that is 0.72, and continued to see a durable event-free survival benefit, almost 20% higher in the treatment group compared to the non-treatment group, with a little bit later endpoint.
This is absolutely terrific. Thank you for this tour of all of the papers in lung cancer. Clearly, many, many impactful studies in here. It's really nice to see Jonathan Spicer, as our thoracic surgery colleague, as first author on a really important study. And I think it serves as inspiration for all of us, for our thoracic surgery community, to please get involved with clinical trial development. There are so many of these breakthrough discoveries that involve us and involve our surgical patients that are actually being led by medical oncologists right now. And so if you are at an academic center or community hospital that is part of cooperative groups, please join the cooperative groups and get in there with the medical oncologists, radiation oncologists to design these trials. All right, so turning now to esophageal cancer.
All right, so there's not nearly as many papers on this topic as there is lung cancer. So there's really one key trial in esophageal cancer this year that I wanted to highlight. So this just came out in January of 2025 in the New England Journal of Medicine, but it was reported at the ASCO meeting in June of 24, and there was a heck of a lot of excitement and interest in this. So I've been eagerly awaiting the publication to come out. This trial is called ESOPEC, ESOPEC, but the New England Journal paper says perioperative chemotherapy or preoperative chemoradiotherapy in esophageal cancer. That's just the way it's titled. And the first author is Heppner, Hoeppner, from January of 2025. This is a trial that was really looking at this concept of FLOT chemotherapy given before and after esophageal resection versus our more traditional cross regimen. And just to fill you in on what those things stand for. So the FLOT regimen is 5-FU, leucovorin, oxaliplatin, and docetaxel, usually given every 2 weeks for 4 cycles, then about a month of recovery, surgery, recovery for however long, 4 to 8 weeks, and then another 4 cycles of FLOT. And this comes from a bunch of prior trials that were based on either gastric, GE junctional, or esophageal cancer. And then the other regimen is the one most of us are familiar with, which is sort of the carbotaxol 50 or 41 to 50 gray of radiation as a neoadjuvant strategy, and then resection. No immunotherapy in either arm, to be clear. So some practices have evolved since this trial started. So it's all adenocarcinomas. 438 patients were randomized. Most of them were CWORT 1 or 2. There was like 2% in each group that was what would be considered a CWORT 3. And it was positive. So this was looking at progression-free survival as well as overall survival, but those rates are pretty immature still. But the 3-year survival was 57% in this FLOT group compared to 50% with the cross type regimen. And the hazard ratio with that was 0.7. But more impressively, I think, is if you look at the median survival in the two groups, and it was 66 months with the perioperative FLOT as opposed to 37 months with the cross regimen. So that is sort of more remarkable to look at. A couple things that many have commented about, though, was that the rate of patients completing pre-op therapy and going to the operating room was surprisingly low in the cross group, like 67%. I think most of us are used to seeing that in the 90 to 95% range in practice. So that very easily could have influenced these findings. And it was about 87% in the FLOT group. So lots more detail to look at here. This is definitely a great journal club paper to talk about at your institution. You can look at the past CR rates and compare them and all sorts of other details that are really important there. But the bottom line is this was definitely what I consider a practice-changing trial, and we have definitely switched over to using perioperative FLOT more and more in our adenocarcinoma esophageal patients. There was another study really similar to this, almost the same design, called Neo-Aegis, that came out about 2 or 3 years ago. And I think it has to do with the statistical design, the numbers in each group and so forth, but it was designed as non-inferiority, which came out that they were considered equal. And for whatever reason, this ESOPEC study is showing that perioperative FLOT is actually superior to cross regimen. So just bringing that up for context, because many of you may have heard of that other trial.
How was it switching from cross to FLOT? And then overall, do you feel that nationally there's still some debate on whether or not to switch over to FLOT?
I think there's going to be a lot of adjustment, and as you can imagine, it's going to take some time for people to adjust their strategies, and it's not going to be adopted the minute it's put in print. The FLOT therapy, we think, is so much better at distant disease control, which is often the cause of death of this group of patients. And so that's one of the reasons a lot of us have been interested in trying something with a bit of a more aggressive, stronger chemotherapy strategy. But there's all kinds of other things. It's a lot harder for people to tolerate. And now we're having to give this after surgery to patients. And that's also really tough in an esophageal resection population. So there's certainly a lot of things to discuss in a tumor board setting. Sometimes people have no access to radiation. And so this could be a better choice than chemoradiation if the person lives far away from a radiation center. So there's different pros and cons to both strategies, but at least now we're starting to see a statistically significant survival and disease-free recurrence benefit with this different strategy.
Definitely. And Linda, I saw you had a Lancet review article as well to talk about.
Oh, yes. This is another, just like at the beginning of this talk about radiation therapy, this is another overview of esophageal cancer. And it's, again, there's not a specific goal to it. It's just to kind of update people on what's happening in the field. And it's everything from diagnosis, evaluation of Barrett's, different treatment strategies. And there are some really nice summary tables that list all of the different perioperative studies that have been done in recent years, just to help people sort of keep up with what's been done, what the results and outcomes have been by histology, by country, things like that. So again, this is a good paper to be familiar with, just to sort of keep up with everything that's being advanced. It talks about some of the driver mutations we're starting to pay more attention to in esophageal cancer as well.
Great. Now, in terms of benign esophagus, I saw you had a nice study about anterior gastropexy for paraesophageal hernia repair that you selected.
Yeah, quite a few of us spend a fair amount of our time doing paraesophageal hernia surgery or other benign foregut work, and we're always plagued with a high recurrence rate, and it's always a little sobering to think about and to explain to patients and everything. So always looking for ways to do better on that front. So this is a paper that just got published in December online for JAMA surgery. So I'm not even sure if it's in print yet. But this was a randomized trial looking at the role of a gastropexy in addition to a standard hernia repair and whether that helped prevent recurrence. Some of us used to put G tubes in as a gastropexy. This is just a suture, so the person doesn't have to walk around with the tube. And the idea was to do sort of like a Carter Thompson suture passer and put a stitch through the greater curve of the stomach in a couple of places. And then you pull it all the way up full thickness through the abdominal wall to help secure the body of the stomach and the abdomen. So it's something I've used at times, but I never really knew how good the data was. So this was 240 patients that were randomized to either have this extra stitch or not after a hiatal hernia repair that was otherwise uncomplicated, wasn't a redo, didn't have a callus gastroplasty, no mesh, anything like that. And the Pexy group had a better recurrence rate of 15% at 1 year compared to 36% without that Pexy stitch. And they tested their patients at 30 days as well as a year with imaging and a clinical evaluation. Not all of us would repeat the Bering swallow, but they did for the study. So that's pretty remarkable to cut that recurrence rate in half. It's not hard to do it. It takes just a couple extra minutes to throw those stitches in. So it certainly gets my attention. I've also seen some different Pexy techniques along the left diaphragm that I'm lately favoring a little bit more, but that was not studied in this trial. So I encourage you all to look at that study and again, sort of talk about the techniques and pros and cons of adding a gastropexy to see if we can combat that horrific 50% recurrence rate.
Exactly. I think it's always really nice to have literature and new data on this topic. Well, Linda, that was a fantastic overview of the esophageal papers. And we're going to move on to this big, broad category that you've labeled surgical professional issues.
Yes, this is my little catch-all for random things that come up. And 1 year we've talked about what type of skin prep to use or what sort of surgical hats are okay to wear. So these are just sort of general topics that have to do with being a surgeon. Some of them are more thoracic specific. So I've got a few here that I found, and you may find them a little random, but they were highly read and cited. So the first one is about an anticipated shortage of thoracic surgeons. This comes from Journal of Thoracic and Cardiovascular Surgery. And this is late 2023, if I remember correctly, but we didn't have a chance to review it last year. And this is, by the way, also by Alex Potter and anchored by Dr. Jeff Yang. Really, truly, there is no nepotism going on here. This is just a really important paper. But your team looked at how many lung cancer cases have been diagnosed over the past 10 or so years, and that there's an upward trend of stage 1, probably partly fueled by screening, but also how many thoracic surgeons there are. So we're going to have more and more patients who are potentially eligible for resection, but do we have enough people to do it is the question. And they found that if you looked at how many patients are getting surgery for stage 1, you would think that would be going up, but it's actually going down. And so maybe that those patients aren't getting any care or they're getting diverted to radiation. Probably some are appropriate to divert to radiation, but it raises the question if we really have enough of a workforce to handle this increased findings of early stage lung cancer with enhanced screening. So that is a good paper to look at. And again, as we start to think about how many residency spots we have in the country, are we adequately preparing for a workforce shortage?
I appreciate you highlighting this study, Linda. For us, what was really striking was that even with younger, healthy patients with no comorbidities, you have way more patients in recent years getting radiation instead of surgery. And so I think typically people have always wondered that maybe the reason why people are getting more SBRT is because you're finding more and more lung cancers that are indolent in folks who are 80 years old with multiple comorbidities. But what we're finding is that just across the board, it doesn't matter if you're young and healthy or if you are older, above 80 years old and have multiple comorbidities, just way fewer operations over the years. And that trend is definitely concerning and something that I really believe as a field we need to pay attention to closely. In other fields like colorectal surgery, the workforce is actually quite young compared to the thoracic surgery workforce. We also looked at that in this paper as well and looked at the age of the radiation oncologists now, the age distribution of thoracic surgeons, and also colorectal surgeons. And the radiation oncologists are much younger than the thoracic surgeons as a whole as well.
Interesting. Yeah. I mean, it raises a whole bunch of other topics about access to care, rural areas. It's hard to just plop a thoracic surgeon out in a low populated area, but does it mean we need to help teach our general surgery colleagues to do this? I mean, anyway, there's so many different ways to look at that. But again, another provocative paper to talk about and think about with your team.
Yes, definitely. Great.
Uh,
And then you have one on comparison of postoperative outcomes among patients treated by male versus female surgeons in Annals of Surgery.
yes. So this came out in January of 2025. But I think another paper I saw on Twitter the other day came out with almost the exact same title, same journal, but as a different paper, a different analysis, and they did not have the same conclusion. So take this with a grain of salt. But this was a meta-analysis of ultimately 15 studies after starting with a much larger number that met criteria. And they wanted to be able to evaluate mortality, complications, and readmission rate by gender of the surgeon. And they found that readmission complication rates were not statistically different by surgeon gender, but mortality was lower. It was 0.93, which was statistically significant out of like 5 million patients or something. And when they looked at sort of what pushed that difference, it was more so in general surgery, patient care, and also in non-elective cases for whatever reason. But they did make a really interesting comment, which resonated with me. And it says, given that female surgeons are compensated less and less likely to be promoted than male surgeons, we should better understand how they're doing compared to their male counterparts. And here we're saying they actually are doing better in terms of mortality. So good argument to pay us more. But realize again, there's another paper came out right after it without the same conclusion. So
Thank you for bringing this really important point. Actually, Linda, I end up finding the paper while we're talking, and this other meta-analysis, it's called Surgeon, Gender, and Early Complications in Elective Surgery. It is also published in Annals of Surgery, and this one is looking at elective operations. It found no difference between men and women, and I think it supports your overall argument. But if I recall, the paper you just talked about was looking at non-elective operations. Is that correct?
it was looking at all types, but then they subdivided out non-elective cases and whether it was a specialty type of surgery versus a non-specialty type of surgery. And the biggest contributors to the better mortality rates were in general surgical cases that were urgent or non-elective. So that's where they felt those were driving the hazard ratios the most. But it was collectively the hazard ratio favored female surgeons' outcomes over male in mortality.
I got it. Yeah. So I think both papers really are supportive and complementary to each other. And I encourage everybody to read them. It's an important contribution to the literature for sure. Great. So then now we have another fun paper.
Yes,
This
two more
is-
papers to go. Two more to
Yeah.
go.
No, this has been absolutely fantastic, Linda. And I really love the range of papers that you've picked here. So this next one is on divorce among surgeons and other physicians in the US.
And again, Annals of Surgery. This is the most highly cited surgical journal, December 2024. And what they did was look at US Census data to see, we hear all these rumors that surgeons have these ridiculously high divorce rates, and certain institutions are known to have even a 200% divorce rate that I heard way back when I was going through training. So is it true? Well, it's not. Surgeons do have a higher divorce rate than other medical specialties. So it's about 21% in this population-based study compared to about 18% for other physicians. But the general population divorce rate is 27%. So both groups of doctors are doing better than the general population, but surgeons do have a slightly higher divorce rate. And they went through and they looked at surgeon gender, age of marriage, number of children, all sorts of other variables, and nothing else came out as significant. So we'd all like to see that be even lower, but I was sort of encouraged to see that it's not as bad as I was led to believe when I was first embarking on a surgical career.
Thank you for highlighting this important paper, Linda. I trained at Duke for general surgery residency, so I think I'm allowed to say that my impression when I was there, our divorce rates were probably the same as any other program. But to your point, the reputation of Duke was that I think in the 80s and 90s, definitely 100% or even 200% divorce rate is what you said. So it's really encouraging for everybody who is going into surgery as a field to know that it's much better than before and it's comparable to other specialties. So hopefully this is something reassuring to folks who are thinking about going into surgery or in the process of training right now.
And
Yeah,
then
go
the
ahead.
last paper is, I thought, was really a catchy name and also a subject that's of interest to many. And the topic of the paper is For the Love of the Game. And it's about, why do we do academic surgery? Are we getting paid more? What are the dividends we get paid that are maybe non-monetary? And so they wanted to say, okay, well, is there a tax associated with being an academic surgeon as opposed to a private practice surgeon? And there kind of is. So this was Emily Grimsley and others published in December 2024. And this was an American Surgical Association paper, which is really hard to do.
And that concludes the key papers of 2024. Linda, thank you so much. That is what a terrific overview. This is always my favorite talk at GTSC. And for those who are listening, this is a true passion of Linda's, which is that she reads papers every week, every month, and starts preparing for this for GTSC months in advance. It's not something that she puts together last minute, and it really shows in the depth and the range of the papers that are selected. We're really appreciative of your time, Linda. Hopefully we'll be able to have you on next year. And for those who are listening and wondering how to get access to these papers, we'll make sure to include links to the articles and slides that have the titles of the articles so that people can make sure to follow up and learn more about the most cutting edge data and literature that is out there for thoracic surgery.
Thank you. It's been a pleasure to be on the show.
Great. Thank you again, Dr. Martin. Appreciate it.
Amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.